This episode is brought to you by Midas Healthcare Solutions. Bridging compliance, patient safety, and proof of controlled substance waste has never been easier. Midas View provides proof and operational efficiency, the only diversion technology that delivers both, real-time visual verification of medication disposal, powered by AI and machine learning to detect improper drug wasting behaviors, seamless integration with your ADC, EMR, and diversion software, making reconciliation fast and identifying outliers with ease. And Rx Intercept, customizable sample collection with a secure chain of custody. Welcome back, listeners. Today, my guest is Denise Bruscino. She is the Chief Diversion Officer for Moffitt Cancer Center in Florida. Denise is a returning guest. Welcome back, Denise. Our previous podcast had a lot of great information. In fact, I will tell you that since that interview, I have found myself telling several others about your consistent process, Denise, and encouraging them to do something similar. So listeners, I really do encourage you to go back and listen to that podcast if you haven't already. It's titled The Art of Investigative Interviewing. Today, we are going to expand a little bit on, I guess it would be the pre-process before you get to the interviewing. I'd like to know, Denise, how do you decide when to take the case to your response team and when do you decide to go to an interview? And I ask this because I really see a lot of facilities struggle with that pre-part. You know, maybe they have software, maybe they're looking at, manual or whatever other reasons. And they're just, it's some of the data is there. It's not so clear that you're like, oh my gosh, we got to remove them from care. But they tend to err on the side of, oh, let's just have the nurse manager talk to this person and have them, clean up their practice. And then I don't even know, if they've got anything in place to then keep track, if there's been improvement, or if they just wait for the manager to come back and say, okay, I talked to him, or no, I don't think it's anything. And then that's it. And I've been doing this long enough now that I'm starting to see, 6 months later, a year later, a year and a half later, that same name comes up and somebody has witnessed them do something that, is like, yep, there's something going on, or the data is even worse and their name comes up again. And when I go back and look, it's like, okay, I kind of told you about this person, a year ago, but you didn't do anything, or I don't know what you did because you didn't follow up to let me know what you did. And here we are. And there's, more data that indicates there really is something. So there's probably was something, a year ago that was going on. So how you have a great process now. How do you decide when this person is going to get in front of you and have that conversation? Not the manager, but you.
So the biggest thing, obviously, is trends. I am very much in favor of trends. When I start monitoring someone, whether it's a trigger, whether someone's reported something, or whether it's just something I have noticed, either through the software that I use or reports that I pull. So I'll look for trends and I'll watch. And, there's always people that have the one-off or, a little odd thing here or there. But when you start to see a pattern in maybe mistakes or red flags or pink flags, as I call them, some things that are not quite stand out as red, but they still look a little questionable. If you have enough of those, I have sort of a checklist that I created for myself, and I use that checklist. And I do also reach out and talk to the manager of that person, the direct supervisor, to say, hey, I'm watching this person. What are they like? I like to ask some questions to get, a feel, because I'm not visually seeing this person. Yeah. And that kind of gives me an idea of behavior. Most of the time, they're one of the best performers on the floor, a clinical lead. They're doing great. Everyone likes them. great nurse, get excellent feedback from patients. Not often do I get from the manager, oh yeah, this person's missing off the floor a lot or odd behavior. So I want to get feedback from that. From there, I kind of decide for myself, is this a low risk, high risk, medium risk? If anybody is medium to high risk, in my opinion, I bring together our rapid group, which is a small group of us, and we will discuss all the facts and all the data that I have collected on this person. And because in our past, when we were first developing our program and building it, we almost got nipped in the butt with practice versus diversion and assuming it was poor practice. And we brought in one or two people and it turns out that it was poor practice. Once we brought them in for an intervention, we did a drug screen, we did a search, and it was just basically ended up to be poor practice. But the third person that we brought in was not poor practice. And they were the one who looked more like poor practice than than the other two that we had brought in. And because they were kind of all over the place, slightly erratic, and we brought them in and it was one heck of an intervention. Turns out though that we did find things in our search and their drug screen was positive. So from that, we started to take on attitude that while there's lots of indicators that can suggest potential poor practice, it's very hard to differentiate between is it truly poor practice or is it diversion? Because sometimes poor practice is because of diversion. And sometimes it's just because it's poor practice. But you can't, with the observations alone, come up with a definitive answer. And if our little rapid team does not feel, especially me, they do definitely go off of, if I cannot definitively say or feel one way or the other, I definitely call in the rapid team. And if collectively we do not definitively feel, that it is truly poor practice, we don't have the ability to confirm it without certainty. So in order to avoid premature conclusions or assumptions, because assumptions are usually never good things, we bring the person in. Like I said, I will do a lot of investigation, a lot of observation. We do bring that person in so that we can kind of substantiate our evidence. Rather, because if it is poor practice, you could pretty well tell as the interview is going on if someone truly has innocence on their side. And at least in my experience, I haven't had anyone who wasn't doing anything ever show any signs or body language or anything like that. So we also feel that it upholds fairness and it's a trust in the process because we treat everyone the same way. So if we bring in a team member, this is kind of how we have made our culture of the diversion practice. So they can't say that they were being, individualized or, targeted, because when we do bring people in, like I was saying in our previous podcast, we bring people in and we focus on, explain to me your practice. Let's focus on how your practice is. We try very hard to avoid being intimidating, which is going to be already. And we try very hard to avoid anything that would be accusatory. Like I never lead with or even really say that we see diversion. I will talk to them and mention things, like explain to me this practice. I have everything listed out.
Yes.
But we just...
Do you introduce yourself as, "Hi, I'm Denise, the Chief Diversion Officer"?
Yes, because unfortunately I've been at this organization for a long time, so people know exactly who I am.
Okay. All right. Yeah.
But I also lead with, part of what I do is to see how practice is. Like, I'm over medication safety and medication administration safety.
Right.
And so part of my job is to make sure that everyone is adhering to best practice standards. I try not to wear the diversion badge,
Yeah. Yeah. Well, and after time, I think you're, like you said, the culture, I mean, word gets out, right? If people have been spoken to and they're back at work and, oh yeah, I, did too many of this or whatever, I need to stop doing that. And so eventually word gets out that not everybody disappears after they come and talk to you.
Exactly. And, if we find that it is more on the side of poor practice, they do continue to be monitored. We don't tell them they're continuing to be monitored. I'm sure they just assume that, but I will continue to monitor. And we'll work with HR, we'll work with their direct supervisor, and we put them on a performance improvement plan. And the people who really have had practice, I will notice their practice change literally within 30 days. You can just see a complete change and trend in their practice, and their attitude about everything. But I feel like, and I know that there's always the argument to where, like, what if it's negative, or like, how can you really tell it's practice? Like, are you, hurting someone's reputation by bringing them in for diversion? My answer is no, we're not hurting their reputation. It is done very confidentially and privately. There is no one else that knows that we're bringing this person in the organization unless that team member chooses to talk.
Mm-hmm.
Any of our screenings, anything like that, are all done in confidence. But at the same time, my argument is, how do you not know that they are not diverse? Like, how do you know they're not diverse? Like, if I can't say that with certainty, then I need to collect more facts. I still need to collect more data. And sometimes talking to the person is how you collect more data.
Absolutely. Yeah. You may get one that is like, okay, and admit it, but you also hear their excuses that just don't make sense with what they can't come up with a rational explanation. And, you had said something, and it's kind of interesting. So I talk about how poor practice could be diversion. But on the flip side, a substance use disorder could result in poor practice. I mean, it's because now your performance is just going downhill. And we get, I think, a lot of caught up in, as you said, that one person that was kind of all over the place, because I've seen that too. And it's like, well, there's not a drug of choice. There's not a clear method. Mm-hmm. It's just like, oh, what are you doing? And so at that point, it might just be that, you're struggling just to perform. And I mean, I suppose it could not be diversion and substance use disorder that's you're bringing to work with you. And maybe they're not stealing, but their practice is just to the point where they can't sustain. They're sloppy now.
Mm-hmm. And, for our organization, and for myself, I should say, I maintain patient safety is number one.
Yeah.
Patient safety is number one. And if someone is truly having that bad of poor practice, they are putting patient safety in harm's way.
Yeah.
And I definitely don't want that.
Yeah.
And neither does anyone else, right? So I do find that the random times where we have had someone that we couldn't differentiate between, and we brought them in, and it really shined a light on their practice. The people who were truly poor practice, it really shined a light on them. They were able to really kind of see. We even had one realize that inpatient nursing was not for her. She realized that her skills, her organizational skills, and her just the way she did things was not the best for her. So she moved to a clinic, and now she excels really well because she realized that was just not for her.
Right.
Which was actually very, I was kind of caught off guard with that when we were talking with her. She kind of broke down and was like, I've been having all these issues. I don't feel like I'm performing at my best, and I really want to. And She did try to work with the patient care manager and HR on performance improvement, but she just basically came to the conclusion herself that this was just inpatient bedside was not for her.
Right.
So she went to one of our outpatient areas, and she's doing wonderful. And the patients love her, and she's doing great, and there's no issues.
Yeah. No, that's a good point too, because you only see what you're seeing. What else are they not doing or doing that is poor practice that could be dangerous?
Exactly. So I do feel that when we bring people in for these scenarios, they understand the seriousness of how much their practice affects patient safety, organizational, reputation, personal reputation of the team member themselves. And, it brings that to light.
Yeah. Yeah.
As a practice. I was going to say, sometimes just when the manager coaches you and talks to you about it, says, hey, this, that, you think about it and maybe you correct it, or maybe you don't, because you maybe don't really truly get the severity of it.
Yeah.
So this is not, like I said, this is not someone who has a minor poor practice. This is someone who has a significant trend in almost every shift, something. Not the person who, every once in a while has something, or maybe is just a little late all the time on giving their medications. It's not those kinds of practice that we bring them in for. It's trends.
Okay. So when would you have, or would you ever have, the nurse manager have a direct conversation with them and bypass the committee? Would it be for those minor little practice things, or would you even say anything to the nurse manager about it if it's just a onesie twosie here and there? Like, I'm not going to even worry about it.
If it's just like a one-off, I don't worry about it. But if I see a couple sort of one-offs, like a couple things, I do reach out to the patient manager. I actually will talk with the patient care manager and the director of the team member. The three of us will have a conversation. And from there, the patient care manager will talk with that team member, and follow our Just Culture algorithm for, coaching, counseling, and all of that. And sometimes, usually when I talk to the patient care manager, I'll even hear like, oh, she's always late, or, they'll notice that maybe there's been a little bit of inconsistency with, or they already have a concern about the person's practice, not anything to do with diversion, not that kind of behaviors, to where they feel that there's any sort of an issue. They can be a little flaky at times. I've had to talk to them before.
that probably makes you sometimes want to reverse course and say, okay, well, mine.
Well, okay, I know. And I know that didn't sound right, because it's definitely not that kind of a conversation. It's I don't know how to say it. I guess I probably worded that one a little bit incorrectly, but now it's, you can just, I don't know. I guess you could just tell in the conversation when I talk with the manager, or just when you've audited enough people and you've watched enough things, sometimes you can just see like, well, this is someone who like over a 3-month time has maybe had 4 things pop up. And they're all different. And some of it is just, it took them 3 hours to waste the medication, as opposed to wasting within 30 minutes, which is what our policy is. Or, they back timed the medication that they gave by an hour, probably, and they didn't scan it, probably because they gave the medication. Now, obviously, it's all assumptions, but there's not enough things happening. People are human.
Yeah.
So no one is going to be 100% of the time.
And I think it is partially based, and I think this is an important thing for especially programs that are new and people that are new in the space. You and I got the sixth sense after doing this for years and seeing enough cases. Does that mean we're always right? No. But we've got kind of a feel for what we hear and what we say and when we should go to the next step. If you're brand new, you're not going to have that yet. And so they may err on the side of, why did we pull this person in? There was nothing here. But there's also the tendency to err on, oh, I don't think it's really anything. I guess I'll let the manager handle it and we'll see what happens. And then that could be a problem too. So, the message might be you have to err on the side of caution, but make sure your culture is one that you're not sending the message that, what are you doing? It's like, let's just have a conversation. And then as you get more experience, then you become a little bit more intuitive, shall we say. But like you said, the data is the data. And if you can't rule it out, then you just have the conversation.
We work in healthcare and we deal with patients' lives every day. I will always err on the side of caution.
Yeah.
Always err on the side of caution. I would rather bring someone in and find out that everything is negative and be much happier about that, and then say, okay, we have a platform we can work with, and help that person improve their practice to be the best nurse or CRNA, APP, whatever that they can possibly be. But we've also had the case where we brought someone in and we didn't find anything on their search. I wasn't convinced that it was poor practice, just through different conversations being held in the interview. And I did see a trend. But, we brought them in and on our search, it was negative, drug screen negative. And so we put them on a performance plan. But I wasn't seeing a significant decrease in trend. So I worked with our security team and we started watching videos of this person. We see them leaving the unit, and it basically came to security through looking through, I don't even know how many footage, and bless them because I didn't have to do that and they did. Notice that this individual was always going to this one giant plant that we have in like a corridor, like a patient area, a visitor waiting area. This kind of off to the side, and noticed that person kept going over there. So security ended up going up there just to check that area out, and found that person was putting some medications there to store and then would pick them up later.
Nothing like storing meds in a patient accessible area.
And so it was a little hidden spot. So and they were putting it was this giant plant and it was in a corner. So they were putting it in this little area behind. It was something you would not even notice because it wasn't in the actual waiting area. It was kind of off to the side, right? Yeah. Where you passed the hallway, you passed by that hallway after the elevator to the waiting area for that unit. Okay. And security found this. And so then we watched some further footage to realize that this team member would, after their shift, go to that plant and then leave, campus.
Yeah.
So we did bring them subsequently, obviously, back in and through questioning, which was definitely approached slightly different this time around, and ready with all of our saved footage to show them. Ended up finding out that this person was in fact diverting. However, they were not the ones who had a substance abuse problem, and they weren't taking the medication themselves. Yeah. They were giving it to someone else. So that's still diverting.
Right.
So you really can't be sure. And I will always err on the side of caution because patient safety is number one. And if someone truly is having diverting for themselves, they have a substance abuse issue, and we want to help them. So for as much care and compassion as we preach to our team members to take care of patients, we also preach to take that much care and compassion to our team members to try to get them help and rehabilitation.
Yeah. And I think that's missed sometimes. It's just looked at more as they'll be offended. It's a privacy thing. What if we're wrong? But I want to circle back. So the drug test. So in that example that you just gave, your process is always to perform a drug test. Mm-hmm. They came up negative. Obviously, you were convinced from the data perspective that there was something, but you were, shall we say, at that point, proven wrong, with no drug test. And what Have you had negative tests before that you just thought, whoa, that I didn't expect? And then how do you handle it? What do you say to facilities that don't do a drug test because they do think, well, what if it's negative and then we don't have a leg to stand on when we have the data? So let's just not do it at all.
Well, like I said, we're first of all not accusing anyone of anything. So when we bring someone in, it's part of our workforce drug policy that we can test at any time. We can test for cause. And poor practice does equate to for cause for us, because when you look at poor practice, I do not know what the reason is for your poor practice. What is the cause of your, putting patients at safety risk? So like I said, it's confidential. I do find in my history that if a team member is offended by it or resistant to it, it's because they have something to hide. And the people who don't have anything to hide, honestly, have no problem. Like HR is always present in the intervention that I do in the interview, and they have the policy on hand. We ask the person to submit to the test. They can decline. Obviously, if they decline, they are terminated. But if you know you're not doing anything, they submit to it and they understand. And we present it very, like I said, nothing is accusatory. We're not accusing them of anything. We're trying to
roll it out.
We're trying to understand their practice.
Yeah.
So how do you, unless you get more data?
Yeah. How do you handle a drug test that is quote unquote negative because they have a prescription? But
so when we will not ask them in the interview if they are taking anything, but we do let them know that when you do your drug screen, if anything does show up, there will be a person that it's someone from the testing, where we send the test to. They contact you, and if you're on any prescription medications, they will ask you for your prescription. And I don't know how it works because the science of that is not my my specialty, but I do know that I guess when they do testing, they have a certain level that based on whatever the prescription is, that they know if someone is over that level, under that level, or where they should be.
Okay.
And so when we get that test back, it has the examiner's notes on it to say that this person has a prescription for this, and they're at whatever level they should be at. So we do not deem it to be a positive test.
Gotcha.
And so we focus on that. And usually a lot of times people will tell us that they do have a prescription. I never ask them if they do. We just let them know that someone will reach out to you to talk to you about your drug screen from the organization that does the drug screening. It's a medical provider that, reads all that. It has nothing to do with us. We take that out of our hands.
Yeah. Okay. That makes sense. Yeah. Our focus most of the time is on controlled substances. That's, everything. When we talk about diversion, that's what it's about. But diversion can be non-controls as well. I mean, theft is theft, right? Do you have any cases of non-controls that you have? I mean, you probably just stumbled upon it, right? It's not something you look for.
Yep. We've had, I've had two in the past offhand that I could think of. We had one that was taking antibiotics. And that was because at pharmacy kind of triggered that they realized that they were having to refill antibiotics more on this one floor. So it made me do a deeper dive into what was going on. Myself and pharmacy kind of worked together on that and realized that one person was overriding antibiotics, a specific antibiotic.
Should that even be on the override list?
And well, on our one floor, it is because of our sepsis alerts. And so, yeah.
Okay.
Then also too, it's not in its own individual QB. So if you open up that drawer,
just get to it. Yeah.
Get to it. We also had someone who was diverting steroids. They were, and that was by some weird chance. We had another nurse come to us, and it was a new nurse, said, I'm working with my preceptor, and I noticed that they keep grabbing the steroid out of an extra medication out of this drawer, because it's a drawer that opens up to a bunch of different things. And the new nurse went to their manager. And so the manager came to me, and we started watching some footage and started, doing some reports, looking through our BD Pyxis reports. And both of them, two different individuals on two different cases, were diverting.
Okay.
Obviously, we didn't drug test them.
Right. Yeah.
We brought them in on a different, actually, no, I'm sorry. We did drug test them. We brought them in the same exact way we do everybody.
Oh,
we searched them. We searched them, steroids on the one person, found antibiotics on the other person too. But we searched them, drug screened them, because we just believe in doing everything very consistency. Everything goes with consistency. I feel that consistency is what allows trust in the process.
Okay.
And it allows for or deters from anyone feeling discriminated against.
Interesting. I'm curious on the steroid one in particular. Did you change the panel that they were tested for, or it's just the same panel which would not have picked up steroids and certainly not antibiotics?
It was actually
you may not remember.
I don't remember that one. They did or not, because our OC Health is the one who submits for that. I don't submit for the drug panel. That's our occupational health, because they're the ones who collect everything. So occupational health sends out. And I don't remember, because this one was a few years ago. This one was probably, around 2021. So it was a few years ago. So I don't remember that's a good question. Now I'm curious. Yeah. I don't remember if we tested for that or not. My first instinct is no, because I don't remember seeing it. But yeah. We take them.
Still did it.
We like to treat everybody, like I said, consistency. I feel that is what builds the integrity of the program.
Right. Okay. Yeah. All right.
Because if they're taking that, what else could they be?
Right. Yeah. Maybe there's another.
Maybe there's another problem. Because I find it's gotten a lot harder. People nowadays are crossing their T's and dotting their I's and being more diligent. So it's become, obviously a little bit harder to differentiate diversion or practice anything.
Yeah, definitely. I agree. Okay, this is great. Yeah, I think one big message that I get from all of this is if you can develop your program so that people just expect if for any reason we feel that patient safety may be compromised, and it could be as simple as something with your charting that you do consistently that it's just off, then we're gonna take it down this path, because it's all in the name of safety. And if you can change and improve, then all good.
I have no crystal balls, so I do not know with certainty what the person is doing or their intentions behind their practice. So I would rather get as much information and find out the whys as possible.
Right. And do it in a more formal manner. And, nurse managers are not really we know they're biased toward their people. Too many of them don't even understand the ins and outs of diversion and wouldn't see it because they don't know how to see it or they don't want to see it. Mm-hmm. And they don't want to be in that position where they're making determinations. If information is sent to them and it's like, okay, talk to them and see what's going on, then it's left up to them to decide, there might be something, I think we should do something else, or no, I'm just going to put them on a performance improvement, or no, I just had a conversation. And then there's not really any formal record of it. So if their name comes up again, you have no formal record, but it puts the nurse managers in kind of this awkward spot. And now they're left to determine whether there's an issue, really, ultimately. And they are not the best people to be in that spot, nor do they want to. Talking to many nurse managers, there's very few that have said, yep, I feel completely qualified. Most of them are like, I don't really want to be the one making that determination.
That's an excellent point, and that's so true, because we've had, in my experience, I've had anesthesia leadership and nursing leadership. none feel qualified or comfortable sometimes having those conversations. In fact, in our organization, they're very happy with us intervening because they don't feel comfortable having a conversation, and from that conversation, deciphering,
Right.
Is this diversion? Is this practice? Is there more of an issue going on that I can't see on the surface? So they actually prefer our assistance with this because, just exactly to your point, they're biased already. It's a team member that they know, that they work with. They're going to see things slightly different than we do, even though you present them with facts. They know this person on a personal level where I don't. Yeah. And they don't want to be in that situation either. What if I had one nurse manager say, what if I make the wrong decision?
Mm-hmm. Yeah. It's a weighty decision. And as you said earlier in this podcast, they often will say, no, this is my best employee. So already it's not a problem. I mean, let's just, you're making a few mistakes. They're watching you, just clean this up.
Exactly. Yep. More often than not, it's your star performer.
Yeah, I know. Every time I hear that, my pink flag went to a red flag, which is horrible because then it's like, don't be too good of an employee.
I know the worry. But when I do have someone with a lot of trends, and the first thing out of the supervisor's mouth is
our employee.
They're so good. Everyone likes them.
They're so helpful.
Yep. And I was like, oh no, because that's those are
yeah, I know.
Those are the ones, right? I've had more of those. Yep. Every once in a while you get the managers like, yep, they're off the floor all the time. They're a little wishy-washy, sometimes cranky, don't want to talk to anybody. We get those, but those are not I would say, and from my experience, those aren't the normals.
Yeah. I 100% agree based on what I've seen. Yeah. Which makes it hard, makes it very difficult. Yeah. And it makes it easy for those who have less experience then to be thrown off by, oh, okay, well, I guess there's nothing going on, because your assumption is that they're going to show some sort of behavior that is concerning. But, healthcare professionals with a substance use disorder are not like the people that you see homeless in your alleys. It's a whole different thing. And we get kind of the stigma of what it looks like. That's what we perceive it to be. And when we don't see it, then it's easy to dismiss any of the other signs.
And that's a lot of what's taught when you're going through education on diversion. A lot of what is taught to you is to pick up on these behaviors. And a lot of the behaviors are, yes, they are things that are consistent with someone who has a substance use disorder. Rather, it is, they're not showing up to work on time. They're wearing long sleeves all the time. They're a little disheveled. They are, maybe a little bit detached from everybody, or they're off the floor a lot, drowsy. And while those things do happen, I find in those instances when we have had people who have been triggered and that's the behavior that we find, I feel that those are the people who have a very deep, long-standing use history. Because now they've gotten to a point where I think that the addiction has really taken a hold of them. Yeah. Where some of the ones where, not to say they were catching them right away, but because I also think once you start to get a little bit sloppy, even though you're the star performer, I do think that that's when addiction is really starting to kick in.
Yeah.
Because you can't help what you're doing.
Yeah. And your job is going to be one of the things that is going to be the last to suffer, because you need that. Mm-hmm. You need to maintain that. You need that income, that image, that place to get what you're getting. And so that will be the last place where you start to fall apart. And you're right. By that time, if you're starting to fall apart, the disease really has a hold on you because you've been maintaining that.
I agree 100%. So that's why I am all about bringing people in, and we make it our policy. Everything is consistent across the board. No one is being targeted. No one's being, lost for word here. Sorry. Discriminated against. Everybody's treated the same way.
Right.
And we treat them with respect. We don't accuse, and we explain our perspective. Like, help me to understand. This is what these things look like. Can you see how this would look to somebody else? Like, can you understand how this can put a patient, in harm? It's all, I feel that it's all about approach. Right. You are not, the organization is not at harm by drug screening somebody or bringing them in to ask questions if you are doing it in a non-discriminatory way. It should be, as far as I know, a part of every healthcare organization's workforce policy about, for cause and non for cause drug screening. So you're abiding by your own policy within the organization, but also too, if you are, because other people know, like, you mean to tell me that your colleagues sometimes don't pick up on it and don't notice it. And it also brings down the morale, because if they notice it, and even if they brought it to attention, but then nothing's really happening, not that they're supposed to know, or it's not your duty, nor should you follow up with them on anything, but they notice if practice is not being addressed, because they can see that the person is either still here or behaviors haven't changed, things haven't improved. And then that brings down the morale, because then it's kind of like, well, if they can do that, then why am I, what's the point? Or, why bother to say anything, because nothing's going to be addressed or not be taken care of. And I don't think overall that brings over a good sense of morale throughout an organization.
Right. Yeah, no, I agree. Well, this is another great discussion, Denise. And again, your program sounds phenomenal. You've done a fantastic job building that program, and it sounds like it's very effective. And I commend you for that. That's great. Thank you for your time today.
Thank you. We've had some hiccups, but we work them out. So I appreciate it. Thank you so much for your time, Terry. I always look forward to it.
A special thanks to our sponsor, Midas Healthcare Solutions. If you want real proof delivered efficiently that your controlled substance waste is compliant and supports patient safety, Midas View finally provides it. Stop at their exhibit at the IHFDA Annual Conference in Frisco, Texas, September 29th and 30th, or visit www.midashs.com to schedule a demo. When it comes to controlled substance compliance, seeing is believing.